Hey gang, I hope your summer is going well so far. I'm sure getting excited to see you in lab next Monday. Um, the info in this lecture from manual muscle testing. Now Claudia and I will just briefly introduce you to MMT or manual muscle testing at the end of our first lab. But this information is going to comprise the bulk of our second lab, okay? But I'm putting the lecture up before our first lab so you can get started on your manual muscle testing assignment, and the information in this lecture will be helpful to you. Now when we get to lab, we're going to talk about the principles and how to do manual muscle testing. There is a handout in the module for you to download that covers everything we'll be doing in lab and a little bit from this lecture too. We will do demonstrations of all the joints that you'll need to know, or all the muscles that you'll need to know how to manual muscle test. You have a manual muscle testing assignment, much like your goniometry assignment, so you guys are going to be presenting a manual muscle test to your classmates in lab. We'll go over how to accurately grade and document manual muscle testing, and there will be lots and lots of time for you to practice. Okay, so manual muscle testing is a procedure used to evaluating how strong and how functional an individual muscle is or muscle groups are. Now, we're talking about how the muscle can move, or the muscle groups move, in relation to gravity and in relation to how much manual resistance the therapist gives it. Okay? Manual muscle testing is an objective measurement. Because we are trained in performing this, it's considered an objective, reliable measurement, documented every single day in a SOAP note. I use manual muscle testing daily, as I do goniometry, to help justify continued therapy. Okay? Also, PTs use manual muscle testing in their initial evaluation to identify what muscles are weak. Also, it can help identify if there's any pathology going on. And then, like I said, I use it in daily treatments to document how much a patient is progressing or their lack of progress. This little picture here shows a student, I believe. This is from a demonstration a couple years ago, testing. What muscle do you think this is? The hip abductor, the prime one, that is testing gluteus medius, okay? So to be able to accurately perform manual muscle testing, you do have to know the anatomy. This is where kinesiology will come to be very, very helpful to you. So you might want to spend a little bit of time reviewing origin, insertion, and action. You also have to have very good palpation skills, and crucially, you have to have really good observation skills. You are going to be watching for substitute motions. You're also going to be watching for maybe some altered movement patterns as you screen the muscle that you're testing, because that's going to give you an idea of maybe what's potentially weak. Okay? For example, if you're going to be testing a shoulder flexor, so the anterior deltoid, and you have the patient go through the range of motion for their shoulder flexion, and you see that they abduct slightly, you might be thinking, oh, I wonder if that anterior deltoid is slightly weak. Okay? Or if you're testing external rotation, you remember the main external rotator is the teres minor, and also supraspinatus helps externally rotate just a little tiny bit. Supraspinatus is mostly abduction, but mostly for ER we'd be testing the teres minor, and they cannot externally rotate. Say they try to abduct their arm more than externally rotate, you might be thinking, oh, I wonder if that teres minor is slightly weak. Muscles can be tested as a group all together, so you can test all of the rotator cuff muscles together, or you can test like all of the quadriceps together since they all extend the knee. And you can also fine tune what position you put the muscle in to emphasize an individual muscle. For example, if you would like to test all of the muscles that invert the ankle, you can test, as in this picture shows, this guy's testing ankle inversion, or you could tease it out and just maybe test the tib anterior, which is dorsiflexion and inversion, and test just the tib anterior or the tib posterior separately. Another good example that I didn't put on the slide for you, but say let's take hamstrings. So hamstrings as a group, you remember, flex the knee and extend the hip. So if you wanted to just test for hip extension, you can, we also have the glutes that help extend the hip, so you can fine tune out whether you want to test the hamstrings for hip extension or you want to test the glutes for hip extension. And by doing that, you would either bend or straighten the knee, because since hamstrings extend the hip and flex the knee, if you have the knee bent, you would not be testing hamstrings, you'd be just testing glutes, okay? And if you have the knee straight, then you would be getting some hamstring action in there as well. And Claudia and I will be showing you all of this in lab. Okay, so essentially when you bend the knee and extend the hip, you are taking the hamstring out of the equation. You're putting the hamstrings at the knee in a position of active insufficiency, and so then you are just isolating the glute max. All right. So certain things can affect how strong a muscle tests, okay? So I mentioned that manual muscle testing is an objective measurement, but things can limit how objective it is. So in goniometry, we have the inter-rater or intra-rater reliability that might make it a little, I don't want to say non-reliable, but that does limit the objectivity of it. But for manual muscle testing, think about if a person is older. You know, an 85-year-old muscle is not going to test as strong generally as a 25-year-old muscle. Also, male versus female, typically males with more testosterone test a little bit stronger than females do. Muscle size, what I mean by that is, you know, a middle deltoid, as shown in the picture here, and supraspinatus, you know, that's a smaller muscle as compared to, say, quadriceps. So often knee extension tests really strong because the quads are a bigger muscle group, okay? Just more general size to the muscle versus like shoulder abductors and shoulder supraspinatus and middle deltoid, okay? So you also then, as you're applying pressure to, say, a smaller muscle group, you don't quite put as much pressure on as you would to a bigger muscle group, and I'll have you guys practice that really well. Fatigue, say you test the muscle at the end of your treatment session and the patient has just performed, you know, 3 sets of 10 of that exercise or whatever, so they're probably going to be a little more tired than they would be if you tested them at the beginning of the exercise session, okay? And then effort. So if the patient maybe is scared of moving that joint through its range of motion, scared of contracting that muscle, maybe there's been injury or a muscle tear, that could definitely limit how strong you test, okay? If they're in pain too, that will limit the strength grade that you get. Also malingering, say there's a you know, some sort of gain, whether it be financial or even emotional gain from being in therapy. If a patient you know, maybe has an idea that they want to stay in therapy for a while, they may not give it their all during a test, and you could potentially get a weak test out of that. So this is a big one here. Some other things that can produce a faulty strength grade or a poor outcome of a manual muscle test. If the therapist is not communicating accurately what they want the patient to do. So I'm going to have you guys practice saying good cues like hold here, don't let me push you down, hold strong. You have to practice exactly what you want the patient to do. I remember when I was a student, my CI told me to manual muscle test his hip flexion, I think. And so he said, okay, push down as hard as you can. And so I did. And I did exactly what he told me to do. And man, he was like, no, you can't push that hard on an actual patient. And I was thinking to myself, well, why don't you tell me something better? Like, hold here, don't let me push you down. So you have to really have good communication with your patient to get a good testing grade, okay? And also, much like goniometry, you may have found when you researched for your project, there are different ways, and even in Clarkson, there's different ways shown of how to do certain goniometric measurements. The same is true for manual muscle testing. We are going to be showing you in Clarkson the consistent, accurate muscle testing positions, okay? And it is up to you as the PTA to know the position, all right? You need to know the basics. And for a skills check, you'll be needing to know exactly the procedure that's shown in Clarkson. It's also up to you as the PTA to consider certain things in the patient's overall history. And then if you have to test in a different position, you would document that, okay? For example, the position for testing hip extension is in prone, okay? Well, what if you have a patient who, because of a spinal pathology, can't lie prone? You need to know the correct position to test hip extension in, but then you also would need to use your best clinical judgment and do it in a position that's comfortable for the patient, knowing that if you change the position, you could end up with a slightly different strength grade based on positioning, okay? Also, too, with a therapist administering the test, so I know to myself how much pressure I, push down on an arm with. Be as much pressure as, say, my male coworker does. So I know that I am always grading somebody at a maximum strength because I know how much pressure I've given. So for consistency, you do want to have the same therapist ideally performing the manual muscle tests at all times. Some considerations to think about for manual muscle testing: it's precautionary when the muscle is inflamed, okay? It's also precautionary if the patient is in a lot of pain, if the tissue needs to be protected or healing further. So one case where it would be absolutely contraindicated would be if the surgeon has said they may not actively contract this muscle. So I'm thinking of like a rotator cuff repair. The patient may not contract the repaired rotator cuff until usually it's at least 12 weeks post-op. So it'd be contraindicated to do a manual muscle test on that healing muscle, okay? If a patient has had abdominal surgery, you do need to use caution when you're testing any muscle, not just the abdominals, or if they have a hernia, because there is this called the Valsalva maneuver. If a patient holds their breath, and that can, for one, that changes their blood pressure, they're at a risk of fainting. So that also would put a risk of tearing out any abdominal sutures, okay? If they're in the acute care setting, you want to use precaution or take care when you're doing manual muscle testing if they have an oxygen tube or any, IV lines or anything like that. Just, don't cut off a vital supply of oxygen to the patient by doing a manual muscle test. And if there is a underlying cardiovascular condition, so make sure you have read the patient's chart thoroughly before you do a manual muscle test. Again, if you don't be careful, they could hold their breath and do what's called the Valsalva maneuver, which would cause their blood pressure to spike. If they're in any risk for a cardiovascular accident, CVA, cerebral vascular accident, a stroke, or if they've had an aneurysm, myocardial infarction, a heart attack. Also, if they have a pacemaker that's at a fixed rate, you want to use care when you test, because you don't want their heart rate to spike. As if they have any cardiac abnormalities or arrhythmias, if they've had a recent embolus, or if they have high blood pressure. Now, you can do manual muscle testing. It is just precautionary in these situations, but you are going to use absolute care and use your best judgment before you cause any cardiac changes, okay? And if you decide not to do it, you would say manual muscle testing is not tested today because of patient's extremely high blood pressure. And also, if the patient has any neurological condition, such as MS or Guillain-Barré syndrome, which you guys, I think, are learning about right now. Do you guys have pathology? Anyway, either this quarter or next quarter for pathophysiology, there are some certain neurological conditions that causes the patient to be very fatigued, and so you're not going to tire them out further by doing a manual muscle test. Okay. Now, there are different methods of testing testing muscles. Okay. So in your lecture handout, I have talked about a couple of them. What we're going to be doing in lab is the break test. Okay, so we are always moving the muscle. We're always testing the muscle isometrically. Okay. So if you look in Clarkson on page 40, there's a chart that lists the grading scale. And if you look at, like, in the middle of the chart, it says if testing through range, don't worry about that. We're always testing muscle isometrically, okay? The conventional manual muscle test is where the resistance is applied through the whole range of motion of that muscle. And a break test is when the resistance is applied at an isometric contraction of that muscle. That's where the cue, hold here, don't let me push you down, comes from. You can, so the break test is where the therapist gives manual resistance. You can also test muscles using what's called a dynamometer. We have one in the lab that I'll show you. This is for testing like grip strength. You can test any muscle actually with a dynamometer. And then there's also a certain machine called a Biodex. I've actually never seen one in 17 years, but they're out there, different ways of testing muscle strength. And you will see too some functional muscle tests. A great example of this is like a sit to stand test. That tests functional strength of quads and glutes, and you'll see that documented very often. Or like a step down test where you might see documented patient has significant genu valgum during step down, indicating weakness of what muscles would that be? Likely hip abductors, maybe quads too for patellar stability. Huh? And the reason why we use the break test is because it is what you see in the clinic. It's fast, it's convenient, and it doesn't cost anything. Okay. So here's a couple pictures of a student, I think, doing a hamstring muscle test here, because they're pushing down on the knee, so the patient is holding knee flexion, and the therapist is trying to break that knee flexion, pushing that knee down into extension. Okay, and then this is a test of the shoulder flexors, anterior deltoid. So you can see here that the therapist always has the other part of the limb stabilized. Okay, so we've got a stabilizing hand and a resistance hand. stabilizing hand and a resistance hand, and actually this hand should be over here on that scapula. Okay. So in general, the patient is asked to hold their limb or whatever body part you're testing at the end of its available range or at another point in the range of motion while the clinician provides manual muscle resistance. Okay. So the patient should be placed in a position that provides overall support to the body so that the patient can concentrate on how much effort they need to put into the test. Okay. So typically, two joint muscles are tested at mid-range. Okay. Honestly, I don't often go at end range. It's not very comfortable for the patient. I am totally fine with you guys testing all muscles in mid-range, and that is what's shown in Clarkson as well. Okay, but you will sometimes see out there patients testing at the end of the available range. I usually tend to fall into at this other point in its range of motion, somewhere around the middle of its range. You'll find muscles test fairly accurately in mid-range. Okay, so don't miss this. Initially, you place the joint or the muscle in its against gravity position. Okay, if the muscle is too weak to function against gravity, then they're going to be tested in a gravity eliminated position. That would be a plane that's horizontal to the muscle. Okay, so first of all, you test the muscle initially through gravity, and if it's too weak, then you place them in a gravity eliminated position. So again, if you look at your grading scale on page 40, you can see how a 3 is delineation for gravity. A 3 means that they have the full available range of motion against gravity. Okay. Generally, the proximal part of the area that you're testing should be stabilized. This helps reduce the opportunity for any substitute compensatory motions, which you have acutely observed for, very keenly watched and saw any substitutes. And then the resistance needs to be applied directly opposite the line of pull of the muscles being tested. So this is where it will be helpful for you to review briefly your origin insertion and how the muscle is oriented. So you're going to be applying resistance directly opposite however those muscle fibers are lined up. Okay, and you put a very gradual application of pressure with a buildup. I think in your notes I've listed like 3 to 5 seconds, and you want to use a long lever arm in most cases. All right, so if you're testing a 2 joint muscle, you'll test over both the joints. Okay, if you're testing a 1 joint muscle, you're obviously going to test over just the 1 joint. And both sides, so bilaterally, you should assess their strength bilaterally so that you can provide a comparison and you know what is going to be considered functional for that patient. Especially you have to test bilaterally when one side is affected by pathology and the other side is not. So when we get to lab, here's what you're going to need to know how to do, especially for your skills checks. And I do have your rubrics posted so you'll know exactly what Claudia and I are going to be grading on. You have to provide the patient a clear explanation of the procedure, and you have to use good verbal cues. If you guys get lazy and just say, okay, contract this muscle, no, that's not going to fly. The patient's not going to know that. You're going to have to describe exactly what you want this patient, not your PTA student lab partner, to do. Okay? You're going to have to position the patient properly for the muscle being tested. And in your lab handout, all of the positions are listed very, very clearly. You also need to make good thought processes and choices about how you're positioned for your own body mechanics, okay? And also how you're going to position yourself to best use gravity to your advantage, so you don't have to work real hard, because you do this all day long, you're going to end up, needing a shoulder PT on your own shoulder if you stand not directly over the patient's shoulder while you're testing it, okay? And then you're going to adequately stabilize the proximal areas of the body to help avoid substitute motion. So you have to know how to stabilize, because you're going to help avoid substitute motions just by how they're stabilized. Also, with your cues, you can help eliminate any potential substitute motions with good verbal cues as well. So, in your skills check, what we will always ask you to do is to do a screen test, okay? First, you palpate the muscle that you're going to be testing. You observe how much range of motion the joint can do, what the action of that muscle is against gravity. You always do against gravity first. That's your screen test. You can do this as a general scan. So again, if you're testing shoulder flexion, you ask the patient to raise their arm up over their head. First of all, you test the shoulder, you palpate the anterior deltoid, and then you ask them to move their arm up over. And if they can move full range of motion against gravity, then you're going to apply resistance to it. If they can only move through the partial range, then you're going to place them in a gravity eliminated position. Again, that would be horizontal to the muscle, horizontal plane to the muscle. Now, this is why I was so adamant that you learn those ranges for goniometry, because you have to know, are they full? Are they half? Are they 3/4? Okay. You apply resistance. Do the brake test method if they have full range of motion against gravity. Okay. You have the patient hold their position and you push in the opposite direction. You cue them to get into the correct position, and then you cue them to hold it there and not let you push them in the opposite direction. Okay. And I think I already said this, typically one joint muscles are tested in a short range, yes, and two joint muscles are tested in mid-range, okay? So again, you palpate first, then you do the screen test. Now, you are watching as you're palpating. You guys are all young and healthy, and most likely you're going to all have muscles that contract well. Sometimes in the real world with patients, muscles don't contract. So then you're watching for, is that muscle like flickering? Is it trying to contract? Maybe they can't move their limb, but you see a flicker, okay? You're also watching for any substitute or trick motions. You always apply force at the right position on the limb, perpendicular to whatever segment you're testing with proper direction. Hand placement becomes critical here, and you guys will have lots of time to practice. You apply the force with a very comfortable hand position, a lumbrical grip, keeping your fingers relatively loose, and your MCPs and IPs are extended a bit, and you give a slow buildup of pressure. We're going to ask that you accurately record the correct muscle grade, and then if the patient is not able to move their limb through the available range of motion, you will need to know how to test in the gravity eliminated position. And in your handout, all of the positions are listed that you'll need to know. Okay? So grading of manual muscle test is used to determine a patient's PT diagnosis and how their progress is assessed over time. And when you're documenting objectively, you're going to be not only putting down a grade, but you're going to be mentioning, like, how are they able to hold the test position? Are they able to move through the full range of motion? Can they overcome gravity? Okay. You also will document whether or not a manual muscle test is painful. All that will help justify continued ongoing care. Okay. So here's the grading scale. All right. So you guys will most likely be comfortable using the muscle the numerical scale. That is 0 through 5, okay? There is also a letter scale, okay, which is like 0, trace, poor, fair, good, or normal. So again, page 40 of Clarkson lists these all out. So let's talk about 0 to 3 here first. So if again, I can't say this enough, if a patient can move the body part through its full range against gravity and hold their body part in the test position, that means they're given automatically a grade of 3, or fair, okay? You might even see F used for fair. A 3 is the absolute most objective observation made during testing because gravity is consistent, okay? The force of gravity is always constant. Now, 4 and 5 with a brake test get a little more subjective because, like I said before, I know how much pressure I give for a moderate, which is like a 4, or how much pressure I give for a maximum, which is a 5, but that might be different than my coworker's moderate or maximum pressure, okay? So, but 3 is always the most objective because of gravity, okay? Gravity is consistent. Now, if a patient cannot move through gravity in the full range, you place them in the gravity eliminated position. Now, a 2, or a grade of poor, or P, is given when the patient's able to move that body part through its complete range of motion, gravity eliminated. Okay, that would be in the plane that's horizontal to the muscle. And then, so 2 is a little subjective, huh? Because, like, you have to know what that full range is, but you're eyeballing it, right? Is it full? I don't know. You're not going to pull out a goniometer, but you're going to eyeball it. So there is a little bit of subjectivity person to person there, okay? A 1, or a trace, is given when there's no visible movement through a parch range, but you can palpate a slight contraction, or like a flicker of a muscle contraction, okay? And then there is when there's nothing happening at all, no flicker, no slight contraction, nothing's moving, then you give the muscle a grade of 0. Okay. Now, again, this is a little bit subjective here because, did you see it? Did you not? I might see it. Somebody else might not. Observation skills come in here too. Okay. Now, above 3, you are going to be testing with gravity. Okay. So because they can all, with a 3 or higher, because they can move that body part through its full range through gravity, then you're going to need to apply additional pressure and see how much the muscle can withstand. Okay, so a 4, or a good, is the patient can hold that body part in the testing position against your moderate pressure. So you're applying moderate pressure in the opposite action of the muscle, and if the patient can hold that, they get 4. Okay? And a 5, or a normal, means that the patient can hold that body part against your maximal or very strong pressure. Okay? So I think of 4 as the patient can withstand your moderate pressure, and then a 5 is the patient can withstand your maximal pressure. And again, let me go back, there's a little subjectivity there too, right? Because, moderate versus maximal, all right? 3 is the most consistent grade overall. Now, you will see some pluses or minuses thrown in there, okay? And if you look in your chart, it does actually list a couple pluses or minuses. What happens is because, say you're testing a patient at their max and you're giving them maximum pressure and they hold it for most of the time, but then they break at the very end, what are you going to do with that? All right? What if you're giving them moderate pressure and they hold it, but then they break at the very end? What are you going to do with that? So you're going to see people sometimes giving pluses or minuses, okay? some therapists discourage the use of pluses or minuses because it gives even more subjectivity to the whole grading scale. Okay, I tend to use them. I actually like the breakdown that's in your chart on page 40. And then in some cases, though, using a plus or minus provide super important information. What I mean by this, if a patient has a 3, they might not be able to use, say, an orthotic effectively, but if they have a 3 plus, means that they have the full available range of motion against gravity and against minimal resistance. And so then that means that they could maybe stand the weight of, the orthotic, the AFO, on their foot, okay? And this will make sense the further you get in through this program, I promise. Okay, so plus and minuses, throwing them in there just to think about. So 5 means that they can withstand your maximum pressure, all right? Like I said, what if they break at the very end, though? I call that a 5 minus, all right? Some people call that a 4 plus, all right? Which means they would withstand like moderate to strong pressure. I say 5 minus, 4 plus, tomato, same thing. That means they break at the end of your maximum pressure, okay? Good, again, withstands moderate pressure, but 4 minus, maybe they break at the end of that moderate pressure, okay? Now 3 plus means, again, they have the full available range of motion. You're against gravity still, because it's above a 3, and they can tolerate some minimal resistance or very, very slight pressure, okay? And at a 3, they can hold the test position against gravity, but they cannot tolerate any additional pressure. So it's like they can move it, but they can't. The muscle is not strong enough to have any more resistance on it except for gravity. So 3 minus. 3 minus means, looking in your text, your text, 3 minus. So you've done your screen test. You see that they can move the muscle through gravity, but not all the way. But 3 minus means they have greater than 1/2 the available range of motion against gravity. Okay. Now a 2 plus would be less than half the available range of motion against gravity. So you're still against gravity here. 2 plus, 3 minus. 3 is your screen test. 3 is full range of motion against gravity. 3 minus is greater than half against gravity. 2 plus is less than half against gravity. Now, if they can't even get half the available range of motion against gravity, then you're gonna put them then in the gravity eliminated position. So a 2 means they have the full available range of motion, gravity eliminated, okay, in that horizontal plane. 2 minus is less than the full available range of motion, gravity eliminated, okay. I actually have even used 2 minus is greater than half, but not full, and then 1 plus, less than half, okay, gravity eliminated. And at a, so I didn't put 1 plus on there, but I have used it before. So 2 minus, greater than half the range of motion, gravity eliminated. 1 plus, less than half the range of motion, gravity eliminated. And a 1, there is no range of motion happening. Your gravity eliminated, so they're super, super weak. But at a 1, there is a very, very slight, you can either palpate it or you see it. You see that slight flicker of a muscle contraction. And 0, nothing's going on, nothing. Maybe they've had a nerve injury. There's complete severance of that nerve. There's nothing supplying that muscle to contract. That's a 0. So when you're going through the procedure, you will be starting always in the against gravity position. And if they're not able to do that full range of motion against gravity, you will need to know how to position that patient in a gravity eliminated position. May I suggest that rather than being overwhelmed and trying to memorize all of them, think through the procedure. Where that muscle is, thinking about how you're going to get that muscle in a position where there's no gravity on it, it's going to be a piece of cake for you, okay? You'll need to know how to accurately stabilize. There's a point on there for doing the screen test. There's a point on your skills checks for accurately palpating the muscle. You're going to need to observe for any substitute motions and place them in a good position so you're not getting substitute motions. You'll need to know where to apply the resistance and what direction to apply the resistance in. You always apply it opposite of the muscle's action. I want you guys to know that there are different positions to measure the same muscle in, okay? I mentioned that once already, but as we did with goniometry, you're going to only be practicing one for each joint, just for simplicity. Don't look at YouTube. There's a zillion things out there. Don't overwhelm yourself, okay? For your assignment, make sure you just show what's listed in Clarkson, all right? That way we'll get through it. That way we'll know the basics. You are going to see different things out there in the clinic, okay? And then we'll show you some different various strength testing functionally that are used also. So note to this that manual muscle testing is quick and inexpensive. Often though, results don't really denote a person's ability to perform functional activities. So here's an example. I mentioned knee extension usually tests super strong with a brake test, but then you get them on the stairs and you notice their knee collapse right away. So sometimes, it doesn't translate always to function, okay? Additionally, a normal muscle grade doesn't necessarily indicate if the patient is ready to return to his or her normal level of activity, especially if it's, high-level sports participation. So say, say you're working with a soccer player and on a brake test, their hip flexion tests strong, but they still are having pain when they try to kick the soccer ball. Okay, you're going to have to do some other functional tests to determine whether or not they're ready to return to sport. A hop test is one I'm thinking of that's often used for a functional kind of sports preparation test, and I can show you some of those when we get to lab. Okay, so like you did with goniometry, you're going to have to practice, okay? Practice testing different people, male, female, old, young, injured, not injured, and really hit home with those cues to cement them in there, okay? I cannot wait to see you in lab. Hopefully you have fun with this. See you soon.